But now, it's Monday morning. The COVID-19 pandemic still going on in full force. And, we've had an expert with us every step of the way since this whole thing began. Dr. Dennis Norem from Mercy Health is taking time out of his schedule once again to hang out with us this morning. Dr. Norem, good morning to you.
Good morning to you guys.
Are you ready to shovel some snow?
No, I'm too old to do that.
Smart. I got to go with that in my house, too. I got to go with that in my house as well. And
fortunately, I live in a condo now, and the only thing I have to shovel is about 10 feet of sidewalk.
Oh, congrats. Oh, nice. Nice. Some neighborhood kid looking forward to a nice payday for that, I'm sure.
Hopefully.
Yeah, hopefully. Lots of stuff to talk about with COVID going on this morning, including this just popped out a little bit ago. Let's see, where do I have it here? Merck and Company say they are going to end development of their two COVID-19 vaccines, and instead are going to focus on pandemic research on treatments with initial efficacy data on an experimental oral antiviral expected by the end of March. So they were one of the ones that we were talking about. We're going to come up with a vaccine. They decided they're going to pull back from that development and work more now on treatment.
Yeah, I just saw that myself, that it popped up. Apparently their vaccine just was not very effective. And this is not unexpected. With all the research in these different types of vaccines, you would assume that some of them just don't work all that well. I think Pfizer and Moderna set a pretty high bar with a 90-95% effectiveness.
Yeah, when something like this happens, do you, I know you don't know their inside numbers, but is this a move that they did by themselves, or do you think maybe a new administration maybe asked them, can you move your efforts somewhere else?
I suspect this was done on their own. Again, if their vaccine isn't very effective, and we already have 2 effective vaccines and a couple more in the pipeline, it's probably a research economic decision to say, hey, that just isn't going to get them anywhere in terms of return on their investment. So, and this is what happens a lot with drug companies. You see this all the time, that they stop research on different drugs because the results just aren't good enough to justify further development. And then if it is not very effective, there's always the danger that they won't get approval. So they'll end up with a dead end anyway.
And how friendly is everybody in this arena? I would assume that even though it didn't work, any research that they did would be very valuable to some other companies. How free are they with sharing some of their research with other companies?
Well, I think the COVID pandemic has been an exception in terms of sharing research. Companies usually want to keep their information very private because there's a large price tag tied to that. But I think, as we've seen at the very beginning, there's been a real group effort to share research because of the necessity to move everything along very quickly. So I suspect Merck has been sharing this information on their vaccine. Now, as far as oral treatment for COVID itself, there's probably a significant amount of sharing there, but there may be a little more proprietary interest there.
Yeah, follow the money is probably the smartest way throughout this whole thing, wouldn't it be?
I think that's a good way of looking at it. Again, these companies are, committed to help end this pandemic and provide treatments, but at the end of the day, they are still interested in making money.
Speaking of the vaccine, now you got a doctor in the UK who is warning the world may need annual COVID-19 vaccine treatments due to variants that we'll be looking at.
Yeah, again, that remains to be seen. One of those additional aspects of this virus that we just don't know yet. As we've seen, there's been several mutants popping up, and it's unclear how effective our current vaccines are. On the other hand, this new type of vaccine, the messenger RNA vaccines that we already have on the market, apparently are able to be modified fairly quickly. So there isn't as big a concern with those mutant variants in terms of trying to deal with them.
You're talking about some variants here. State of Michigan just shut down all collegiate athletics for at least 2 weeks due to fear of the new variant. Is the new one we're talking about? We seem like we do this every week. Is it more deadly? Is it more transmissible? Are the vaccines working on this one? Do we not know the answers to any of those questions yet?
Well, my first comment is if they shut down the athletics at the University of Michigan, I wouldn't have any problem with that. Hopefully they'd make that permanent. But no, getting back to the issue, which, again, it hasn't been worked out quite yet. Clearly, these new variants are more contagious. I think they pretty well established that. And they'll probably become the dominant viruses in the next several months. It's not clear yet if they're more deadly. At first, the UK variant did not seem to be more deadly. However, I think the data isn't in yet. There isn't enough information to know. Certainly, if it's more contagious and it affects more people, then kind of at the end of the day, you could say, well, it could be a little more deadly just because it's more widespread. But I don't think there's enough cases for them to analyze to see if specifically it is more deadly. I think there's more of a concern about the South African variant and the Brazilian variants, which I don't think are in this country. Those seem definitely to be a little more deadly.
And to take a quick pause from the COVID talk, are you an Ohio State guy?
No, I'm an Illinois guy.
Oh, okay. Your vitriol towards Michigan I've heard Ohio State people
You've been
talk
pondering
that way.
this entire conversation.
Well, I didn't really listen to what he said. I was thinking about the
I
Michigan
didn't listen
hate.
to the COVID thing. I just kept thinking about the Michigan hate.
Well, when Michigan plays Ohio State, that's a tough one to know because I think Ohio State's number 2 on my list.
Okay, that's
okay. So a painful tie would be our best result
right.
there. Back to the guy in the UK, Anthony Harnden, physician who advises the UK government, says we may find ourselves in a situation where we end up having to have an annual coronavirus vaccine to cope with emerging strains. He said, think of it like you would think about going to get your flu shot. Maybe add that it would be something that would be added to your to-do list around fall is, I got to go and get my flu shot, my COVID shot every year.
Yeah, and I think that's a pretty good analogy. As you know, there's numerous strains of flu. There's basically the 2 types, the type A and the type B. And every year they modify the shot slightly to try to include what they think are the predominant strains. And we may end up with that happening with the coronavirus. The hope was with the newer type of vaccines, the messenger RNA, which these are the first 2 that have been commercially used, we would get a little better overlap and not have to change the vaccine quite as often. So there was hope that with the messenger RNA vaccine for flu, that you might not have to get it every year or it may not have to be modified every year, but that remains to be seen.
How's the vaccine numbers at your guys' office? You guys stockpile yet, or do you know when you're
really,
getting more?
There's no stockpile. I think that the health system has done a pretty good job of vaccinating everybody who wants to be vaccinated, getting their first and second shots. So I think in terms of that, we're in pretty good shape. Now I see the state is rolling out the 1B category with the over 65 and the essential workers. That's supposed to start this coming week across the city. Unfortunately, there just isn't much vaccine. I think, as you've seen on the news, most places are using the vaccine as fast as they're getting it, and it's not clear how quickly they're going to get additional doses.
We talked a little bit. There was a report that came out. I think it was Friday that Joe and I got into this one. The Journal of the American Medical Association warns that patients with a history of allergies to food, animals, insect stings, or medical products should be observed for up to 30 minutes after receiving the vaccination, and that plenty of epinephrine should be nearby at vaccination sites. CDC identified 21 cases of anaphylaxis among almost 1.9 million people getting their first dose of the drug. It breaks down to where it's about an allergic reaction for 11 cases for every 1 million doses. And if you were going to compare that to the flu vaccine, it's, 1 case per every 1 million.
Right, I said, it was 10 times more deadly.
10 times more deadly.
That's the article, the headline they needed.
Some will bend it that way. What's your take on the allergic reactions?
Well, I hope you wouldn't use the word deadly. I don't know that we've had any deaths at all.
No deaths from anaphylaxis have been reported.
This being a new material in terms of vaccine and no one's been exposed to it, I still think those are pretty safe numbers, 11 out of over 1 million. And I think that the extra caution, I can understand that. People who have had significant reactions to those substances in the past probably need to make sure that they have their vaccine in a facility that has the ability to treat them if there is a complication. For most of us who don't have any kind of reaction in the past, wherever you can get it is fine. Again, I would emphasize there haven't been any deaths.
I used all of my experience of not being a doctor to make the analogy when we did this. It's kind of like the difference between having a gluten insensitivity, a gluten sensitivity, and a celiac disease. If you have celiac disease, you know what's going on. If you're allergic to stuff enough to be concerned, you're not just affected by your cat dander or something. You already know how to take care of yourself. Is that accurate at all?
That's good. People who have anaphylactic reactions hopefully would have their EpiPens with them anyway. So if they were in a situation where there was a concern with the vaccine, for instance, hopefully they would already have their EpiPen, and the facility would have the ability also to give them epinephrine. So I think caution is important, but again, the vaccines have been really safe.
Yeah, CDC officials add this is exceedingly rare. They want people to continue to sign up. No deaths from anaphylaxis have been reported. 95% are known to have been discharged home or have recovered by the time of the report to the Vaccine Adverse Event Reporting System. Average onset of symptoms about 13 minutes. One case, it took 2.5 hours before the patient suffered an allergic attack. For 18 patients, they experienced anaphylaxis within a half an hour.
Yeah, so I think that's why they picked that 30-minute interval. I know the standard interval, I think, for our vaccine here has been 15 minutes, and again, exceedingly rare.
And most of your staff have received both shots. It's been, I think, a couple of weeks now. Everybody fine? Everybody, any extreme side effects?
I've not heard of anybody having extreme side effects. What's interesting, having talked to some family members elsewhere and some of the staff members, occasionally there's been a person who's had a significant fever, which I found interesting. Some people have had almost a flu-like thing, which is kind of what you expect, headache, muscle aches. But whatever the reaction has been, I think most people have told me it's gone within that 24-hour period after the shot.
Well, that's good to know. A couple of notes before we let you go. I see Wisconsin showing their lowest daily COVID-19 total since September. COVID-19 deaths slowing in Texas. The Dakotas, virus hospitalizations down to their lowest total since August 20th. These seem to be positive notes.
Absolutely. I think even here in Illinois, our overall rate is down around 5%, which is the lowest since October, November. And overall rates across the country certainly have dropped with some significance. So the hope is we're on the downside. The concern, again, is all this discussion about these more contagious strains taking over. Will that bump our rates again? We just don't know. But again, I think we got to look on the positive side and say maybe we are getting on the downside here.
How long would it take from one of these new strains to pop up in the area for us to know if it is going to be much more contagious than before? I mean, we find it, and in a week, in 2 weeks, we don't need to be any more or less concerned than we already have been?
I don't think we need to be any more concerned. I know the state is surveying, looking for the newer strains and watching things. So I think we don't need to be more concerned. We know the vaccine is still effective. We don't know if it's quite as effective against these new strains, but it's pretty clear it's going to still be effective. So we just have to, move on, do what we're doing, get your vaccine as soon as it's available, continue your PPEs, your social distancing, and be cautious, and hopefully we're moving in the right direction.
Just one more question about the new strain. How do you guys, the medical profession, know if somebody gets the new strain? Because, I mean, are the tests that we have, do you get a different result coming out of it? I mean, it's obviously still positive, but what's the flag that shows up that this is different?
It has to be done really through the state and the health departments and the hospitals, that they survey the strains as they come in and do a specific testing. So the testing that we do to test you for the COVID will not tell us specifically what strain. But as those results go into the labs, they do a surveillance testing. So they have to do some special testing to figure out what the strains are.
Gotcha.
And they're doing that kind of routinely all along. They do that for flu. They do that for other contagious diseases that have multiple strains. So we have to kind of wait for them to tell us, hey, that strain's popped up in the community.
And what's the turnaround on that usually?
Good question. I don't have a good answer to that. I think that they can turn that around within a week or so.
Okay.
That's pretty
Sometimes
quick.
they have to send specimens sometimes to Atlanta to the CDC, depending on what their availability of testing is.
All right, that's a pretty quick turnaround. Even though you'd like to have it instantaneously within a week is pretty good for keeping track of those things.
I think they're set up to do that, to be able to tell that.
All right, well, another week is in the books. At least it seems that there are some progress that we're seeing, some positive steps, and hopefully we'll carry that through to when we get together next week and kick this very topic around. Dr. Norem, as always, we appreciate the time and the expertise.
Well, appreciate it, guys, and I agree. I hope we can see that our overall rates continue to drop along with our hospitalization rates.
That would be great to see.